Good afternoon, everyone. Today we are going to discuss syphilis. Today we are going to discuss the clinical features of syphilis, and in the next class we will discuss lab diagnosis and treatment of syphilis. Now let's start. What is syphilis? Syphilis is the sexually transmitted infectious disease. It is also called great imitator because there are various clinical features of the syphilis. Males are affected 8 times more commonly than women in syphilis, and most common age group is 35 to 44 years for male and 20 to 24 years for female. And the causative organism is Treponema pallidum pallidum. Treponema pallidum is a spirochete and it cannot be grown in any other biochemical media, and rabbits are used in laboratory research. In dark field microscopy, the spirochetes appear as pale white corkscrew-shaped organisms with regular coils, and they are actively motile. It rotates around its long axis and appears to move slowly backwards and forwards. This is the pathognomic feature of Treponema pallidum. And it cannot be cultured in artificial media, but can be propagated in organ culture. Now this is the picture showing the spirochete in dark field microscopy. As you can see, pale white corkscrew-shaped organism. And these are the best spirochetes in fluorescent microscopy. And they move around its long axis, backward and forward movement. In the natural history, there are 4 stages of syphilis: primary, secondary, latent, and tertiary syphilis. And the first 2 stages, primary and secondary syphilis, are contagious, right? And they do not last more than 2 years. But latency may last from 5 to 50 years. Now the incubation period of syphilis, the incubation period is 9 to 90 days. And mostly the genital primary source appear 3 weeks after exposure to the bacterium. And the enlarged glands appear in one groin after further 1 week, that is a 4th week, and in both the groins in 5 weeks after infection. And serological tests are reactive at 5.5 to 6 weeks. Macular rash appear at the 8 weeks, papular at 3 months, and condylomas at 6 months. Now this is the natural history of the untreated syphilis. If the syphilis is not treated, first of all there is inoculation, and in 10 to 90 days incubation period, there appears the primary syphilis. Okay? We will discuss the clinical features of all these stages of the syphilis. And after appearance of the primary lesions, after 3 to 10 weeks, then if there is hematogenous dissemination and if it is not treated, it progresses to secondary syphilis. And after secondary syphilis, after 3 to 12 weeks, it progresses to latent syphilis. However, up to 25% of the cases of latent syphilis may relapse within 1 to 2 years and give a clinical feature of secondary syphilis. And remaining cases of latent syphilis, either they cure by themselves due to host immune system or progress to tertiary syphilis in 2 to 20 years. Now the transmission is almost during sexual intercourse or genital contact, and these spirochetes enter the body through breaks in the epidermis as skin or mucous membrane. However, sometimes in deep inoculation, as like that of accidental puncture by needle or in transfusion, there is absence of primary lesion, which is called syphilis DMD. And the congenital syphilis is acquired through placental transmission, that is vertical transmission. And longer the mother had syphilis, the less likely it is to transmit to her child. Now the clinical features of primary syphilis. Primary chancre. Okay? The lesion of primary syphilis is called chancre. It appears at the site of initial treponemal invasion of the dermis. And initial lesions are papular, which ulcerate. Right? And you should be able to describe the typical lesion of primary syphilis. It is also called chancre or Hunterian chancre. How is it? On examination, the Hunterian chancre is regularly aged, regularly based, hard, button-like ulceration up to 1 centimeter in diameter, and it is painless, right? And it is surrounded by narrow border 1 to 2 mm wide. However, it can be painful if there is secondary infection, but the primary lesion is essentially painless. And there can sometimes be hissing ulcers that are shaped like hourglass. And 50% of the lesion of primary syphilis may be atypical, means not as that we have described earlier. Mostly the chancre is single, but sometimes there can be multiple chancres. They persist for variable period, but rarely exceed 3 months. They usually heal in 3 to 8 weeks period. And in about 1/3 of cases, after healing, they leave depigmented atrophic scar. And after a week of appearance of primary chancre, that is Hunterian chancre, there is swelling of the inguinal lymph node, which is initially unilateral, then it becomes bilateral after 1 week. The lymph nodes are discrete, rubbery, and free from the skin and underlying tissue. Now, the most common site for Hunterian chancre are in male, it's a glands near the frenulum and underside of prepuce. It's less common in pubic region and external meatus. And in homosexual patients, it can be seen around anus and rectum. In women, chancres are less frequently demonstrated. The sites include cervix, labia majora, minora, and around the urethral orifice, clitoris, and posterior commissure. Extragenital sites that can be involved are tongue, tonsils, fingers, and mouth. You can see this is a typical Hunterian chancre. On examination, these lesions are indurated, button-like, hard, and painless. These are also picture of Hunterian chancre. This is the Hunterian chancre over the urethral meatus, in the perianal region, in lip, and after the primary lesions appear, there appears the secondary syphilis. It results from hematogenous and lymphatic dissemination of treponins. And in secondary syphilis, skin and mucous membranes both are involved, and serological tests are always positive in secondary syphilis. The typical clinical feature of secondary syphilis lesions are they do not itch. There is no itching. They are coppery red and symmetrical distributed. They first appear at around 8 weeks, 2 months, which are initially macular, but they become papular by 3 months. And the constitutional symptoms like fever, headache, bone, and joint pain are also present. Now there are various clinical features, various types of lesions that are seen in secondary syphilis. The first one is macular syphilitis. It is also called roseolar rash. It is the earliest lesion seen. They are symmetrical, coppery red, round and oval spots. They follow the lines of cleavage. And there is one term called leukoderma syphiliticum, or the necklace of Venus, in which there are healing lesions which are depigmented, and they appear like depigmented spots on a hyperpigmented background on the back and sides of the neck. These are called leukoderma syphiliticum, or the necklace of Venus. And you can see macular syphilis, multiple coppery red, symmetrically distributed lesions. and these follow the lines of cleavage. Now the papillary syphilis. There are two types of papules, early papules and late papules. Early papules tend to be cynic and they are covered with thin layer of scales. Late papules are nemular, 1 to 3 centimeter in diameter and covered by massive layers of scales. And on macerated skin surface and mucous membrane, eroded weeping papules may be seen. And these eroded weeping papules have tendency to hypertrophy. As you can see, these are the papules, multiple coppery red papules with scaling. These are symmetrically distributed. And remember, the lesions of syphilis do not itch. There is no pruritus. And sometimes condyloma lata are also seen. Condyloma lata are the hypertrophic coalesced papules which are present around the anus or vulva. And in men, they can be seen in glans penis, coronal sulcus, and inner aspect of prepuce also. And in late stages of pregnancy, hypertrophic coalesced sudden surface papules may be very pronounced. And the late papules are irregularly distributed and they have the predilection for certain sites like corner of mouth, angle of nose, palm soles, and beneath the breast or axilla. And sometimes these papules are seen along a line of the hair margin, which is called corona veneris. As you can see, the lesions along the line of hair margin, these are called corona veneris. These are the condyloma lata, hypertrophied, moist papules. These are also condyloma lata. Over the perianal surface, condyloma lata over perianal surface. And there can be micropapular lesions also. There can be corimbose lesions. Corimbose means with large central papule which are surrounded by small satellite papules. And there can be luis maligna. In luis maligna, there are ulcerated nodules. These are mostly seen in patient with HIV infection. You can see these are luis maligna lesion of secondary syphilis. These are ulcerated lesions seen in case of HIV. And in other areas, apart from the skin, in the hair, there is moth-eaten alopecia, that is patchy alopecia. In mucous membrane, the surface epithelium is grays, which forms round or oval patches over the palate, inner aspect of lips and cheeks, and these patches may coalesce to form snail track ulcer, snail track-like ulcers, and bilateral syphilitic tonsillitis may also present. In 50% of the cases, there is generalized lymphadenopathy, and the lymphadenopathy is painless, discrete, rubbery, mobile, and varies from size 0.5 to 2 centimeter. You can see grayish-white mucous patches. In the systemic involvement, there can be headache, there can be involvement of CSF, there can be panuveitis, periostitis, joint effusions, glomerulonephritis, hepatitis, gastritis, myocarditis. And the lesions of secondary syphilis resolve spontaneously in a variable period of time. And most patients enter the latent stage within the first year of infection. However, in some patients, especially the immunocompromised patients, the lesions of primary and secondary lesions may reoccur. These are the scaly, asymptomatic papules over palms in case of secondary syphilis. You can see papules and plaques over soles. Now the latent syphilis follows the secondary stage, and this stage of the syphilis is asymptomatic. Okay. The person has serological evidence of syphilis but is asymptomatic and has never received treatment for syphilis. Right? If the patient is latent syphilis, they may remain in the latent syphilis stage indefinitely or interrupted by relapses of the secondary syphilis, or may progress to tertiary stage. It is diagnosis of exclusion and ideally requires CSF examination to rule out neurosyphilis. Latent syphilis is further divided into two stages, early and late. Up to 2 years, it is called early latent syphilis, and if it is of more than 2 years, it is called late latent syphilis. Now the tertiary syphilis, 1/3 of patients, untreated patients, may progress to tertiary syphilis and remain in this after 1 to 20 years. And there are 3 types of tertiary syphilis: benign tertiary syphilis, cardiovascular syphilis, and neurosyphilis. In benign syphilis, there is no involvement of cardiovascular and nervous system. Mostly the lesions in benign syphilis is seen due to cell-mediated inflammatory response to the treponins. And the characteristic lesions are called gumma. These gumma may be single or multiple, and it breaks down to form ulceration. In gumma, there is central caseous necrosis, which is surrounded by a zone of granulation tissue and fibrous tissue at the peripheral margin. It heals with scarring and spreads peripherally. As you can see, these are the gummatous lesions. The lesions can be nodular. It is deep indurated, pinnate to pea-sized, archiform pattern. Archiform means incomplete circle pattern. As you can see, this is the archiform pattern. The most common sites are face, scapular, interscapular region, and extremities. It can be psoriasiform, like psoriasis, and hyperpigmented scaly plaques, mainly seen over palms and soles. There can be subcutaneous gumma also, which is painless. The most common site of subcutaneous gumma are legs, scalp, face, sternum, and sternoclavicular joints. Gummas can also be seen in mucous membrane, like mouth, throat, palate, pharynx, larynx, nasal septum, and in mucous membrane. These are gummas. In tongue, we can see deep irregular forming of the tongue with patches of necrotic epithelium, which is called leukoplakia. You can see grayish white patches over the tongue. These are leukoplakia. And in late benign syphilis, the bones are also involved. Right? Mostly the long bones and bones of skull and shoulder. And there is deep-seated pain over the bones, which is worst at night. The overlying subcutaneous tissue may be involved. And if the nasal septum and hard palate is involved, there can be perforation also. Gummatous osteoperiostitis of the skull bones give the appearance of worm-eaten skull in exterior. As you can see, there is a nasal bone perforation giving rise to Saddle-Nose deformity. This is nasal septum perforation. And there can be involvement of viscera also in late benign syphilis. If there is gastric involvement, it sometimes can be hematic mesis due to esophageal varices. Sometimes gummas can also be seen in liver. This gives rise to diffuse interstitial cirrhosis. Cardiovascular syphilis is seen 10 to 40 years after the onset of infection, and men are more frequently affected than women. And 40% cases of cardiovascular syphilis may have involvement of the nervous system also. And the classification of cardiovascular syphilis is syphilis of the heart, syphilis of the great vessels, which involve uncomplicated aortitis and aortic aneurysm, and syphilis of the medium-sized vessels. Neurosyphilis. Now, with the advent of antibiotics, the cases of neurosyphilis have decreased. But neurosyphilis is commonly seen in HIV patients, immunocompromised patients, and the neurosyphilis can be classified as asymptomatic. This is early and late, Meningeal, which includes acute syphilitic meningitis, meningovascular syphilis, cerebral and spinal syphilis, gummatous, which is cerebral form and spinal form, and parenchymatous. General paresis, stapes dorsalis, taboparesis, and optic atrophy. Now the congenital syphilis, it is due to vertical transmission. If the mother is primary syphilis and is pregnant, there is 70 to 100% chances of vertical transmission. Right? If the mother is in phase early latent syphilis, there is 40% chance of vertical transmission. And if the mother is in late latent phase, there is 10% chance of vertical transmission. And longer the interval between infection and pregnancy, the more benign is the outcome in the child. Now the congenital syphilis is divided into two stages, early and late. If it is within first 2 years of life, it is early congenital syphilis. After 2 years, it is late congenital syphilis. And the clinical feature of syphilis are generally not present at birth. They develop at around 3 months. The skin lesions that are seen are vesicobullous lesion. Remember that in case of syphilis, vesicobullous lesion are only seen in case of congenital lesion, not in other stages of syphilis. Vesicobullous lesion, which are also called pemphigus syphiliticus, which are most commonly vesicobullous lesion, are most commonly seen in palms and soles. These are multiple, discrete, and contain dense blisters, which contain serous or seropurulent fluid. And these lesions may be followed by maculopapular rash over face, mouth, anterior nares, buttocks, palms, soles, and there can be radiating fissure around the angle of mouth, which leave linear scars, which are also called braggers. And there can be syphilitic paronychia and alopecia also. Remember that clinical features of early congenital syphilis is like that of secondary syphilis, and the clinical features of late congenital syphilis is like that of tertiary syphilis in adult. In early congenital syphilis, there is involvement of mucous membrane also, in which there is smooth grayish-white mucous patches over the palate, tongue, buccal mucosa, genital mucosa, pharynx and larynx. There can be erosions and snail tract ulcers. We have already seen that snail tract ulcers are also seen in secondary syphilis. Condyloma lata, which is seen in secondary syphilis, can also be seen in early congenital syphilis. There is one term called snuffles. Right? This is the persistent rhinitis with discharge. This is profuse and purulent and blood tinged, and it is highly infectious, which may lead to perforation of nasal septum with flattening of the nasal bridge, which gives rise to saddle nose appearance. And in bone lesions, the most common is osteochondritis. Right? Osteochondritis of the upper end of the tibia, which results in the pseudoparalysis, which is called parrot pseudoparalysis. However, osteochondritis may involve distal end of radius and ulna. And in radiography, we see sawtooth appearance of epiphysis, periosteal reaction, and loss of density on the medial side of upper end of tibia, which is called Limburger's sign. There is epiphyseal separation. There can be diphyseal periosteitis also. There can be osteomyelitis due to gamma also. In systemic association, there can be hepatomegaly. Hepatomegaly with or without splenomegaly is seen in 33 to 100% of patients. There can be glomerulonephritis and generalized lymphadenopathy, which is usually discrete, hard, and non-tender. And there can be asymptomatic CNS involvement in 80% of the infected infants. Now, the late congenital syphilis, it occurs after 2 years of age. And the gommas are seen in late congenital syphilis, typically as nodules, nodulo-ulcerative or subcutaneous lesions, as we have already discussed in secondary syphilis. And these gommas may lead to nasal septal and palatal perforation. There is one term called Hutchinson's triad. Right? It is seen in late congenital syphilis. The Hutchinson triad involves 3 clinical features, that is interstitial keratitis, peak-shaped upper incisors, and 8 cranial nerve deafness. It is called Hutchinson's stride. And there can be hearing loss. It is mostly present at around 8 to 10 years of age. There can be bilateral hydroarthrosis, which is called Clotton's joint, which involve knees, elbows, and can occur between 8 and 15 years of age. And in 1/3 to 1/4 of cases, there can be asymptomatic neurosyphilis also. Symptomatic neurosyphilis is rare in case of late congenital syphilis. There are also the stigmata of syphilis. Stigmata means scar and deformities that are seen for a long time after once the patient is infected. Right? The stigmata of syphilis that is seen in congenital syphilis, the most common stigmata are frontal bossing, short maxilla, saddle nose deformity, right? Protruding mandible, high arched palate, mulberry molars. Mulberry molars means there is extra deposition of enamel over the molars. There is periolar fissures or raggeds. We have already seen the picture. Bilateral knee effusions, sternoclavicular thickening, severed tibia means bowing of the tibia, flaring of scapulus, mental retardation, and hydrocephalus. These are the stigmata of syphilis. Now this was for today. These are the clinical features. In the next class, we will discuss lab diagnosis and treatment of syphilis. Any questions? If you have any questions, please type.